Okay, thank you very much. Data. What a problem. We'll come back to that. So our next speaker is Julian Edlin. He's here already, who has been a supporter of this organisation before. I do remember him speaking here before, I think a few years back.
Yes, something like that.
And obviously he's very involved in some of the multi-centre collaborative trials. He's a professor of oncology, and I'm delighted that he's going to give us an update on this occasion on SIRT, presumably for cholangiocarcinoma.
Yeah, indeed, specifically for cholangio. So thank you very much for the invitation to AMMF. And yes, I will be talking today about SIRT for intrahepatic, trying to bring some update about this might be a bit difficult to bring many new data on this because it's quite a rare tumor, quite rare treatment, and so data is not accumulating as quickly as we would like. I will not talk much more about epidemiology, just to say that if a type of cholangio is increasing, it's certainly intrahepatic cholangio, and we might think about local regional treatment more easily for intrahepatic cholangiocarcinoma because we have different tools, and I will talk about one specific tool. Another point as an introduction is what we are expecting for liver-only intrahepatic cholangiocarcinoma, because we have a lot of data for all-comers advanced biliary tract cancers, but as we previously stated in this conference, this is a heterogeneous disease. There are, in fact, lots of different diseases. And maybe outcomes for liver-only intrahepatic cholangio, for which we are thinking about local regional treatments, are a bit different. And we are lacking strong data on this, but Angela previously showed that, indeed, outcomes from for patients with liver-only intrahepatic cholangiocarcinoma might be a bit better than what is usually seen in all-comers advanced BTC patients. So we might want to keep in mind these figures because we have a little bit probably better outcomes than in all-comers BTC patients. So coming to the point, what is SIRT? So SIRT stands for selective internal radiation therapy. So this is a type of radiation, as Maria talked about this morning. So this is not a radiation that we deliver externally, but we deliver it internally. So this is a nuclear medicine treatment. We bring a radioisotope, yttrium-90, and we deliver it with the help of interventional radiologists via an angiography. So we do put a catheter in the hepatic artery and to try to go as selectively towards the tumors, and when we are near the tumors, we delivered microspheres that are labeled with the radioisotope. So we bring the spheres within the tumors for them to deliver the radiation on site. So this is a different way to deliver the radiation. So there are pros and cons for that, but one interesting thing is that it is delivered where the tumor is the most vascularized, so within the real living areas of the tumors. So as regard to the data available for SIRT for intrahepatic cholangio, most of the data we have is from low-level studies. Most of the times, we have retrospective studies, frequently single center, but with accumulating data. In a recent review we can see that quite a lot of patients have been treated with this treatment. So we are accumulating evidence, but mostly from low-level studies. When we do look at this literature, we do see that there is a very heterogeneous population. Sometimes we use it as the first treatment in case of advance. Sometimes we use it as a treatment after failure of multiple lines of chemotherapy or immunotherapy. Sometimes we use it when the tumors is unilobar from only one side of the liver, and sometimes when both sides of the liver are involved. And some centers use that when extrahepatic disease are even present. Also, we can use it concomitantly with standard of care chemo, or we can use it when the tumor is refractory to chemo. So there are very different populations in which we can use this. And of course, when we use a treatment in different settings, we have heterogeneous results. And depending on the series, you can see that the response rates are quite different. And of course, survival also will be very different depending on the population you focus on. Currently, I'm afraid to say that the highest level of evidence comes from a prospective study with only 41 patients involved. So clearly, we do have a lot of work to do because we have limited evidence from prospective clinical trials in this setting. So the MISFEC trial was a French trial. We use there a SIRT as a first-line treatment in concomitance with chemo. So we started chemo and we delivered SIRT at the same time. This trial was positive in the sense that we improve response rate upon what is expected with standard of care chemotherapy only. And more importantly, we do clearly improve disease control rate. So most of the patients had disease control with this treatment, while with chemo only, a lot of patients have refractory and do progress under chemo. Secondary endpoints were promising with some suggestion of improved survival upon what is expected with standard of care chemotherapy. And one important point, and I will talk about that, is that we included only patients for which at the MDT the surgeon has said the tumor was not operable upfront. And in this trial, and there are other series suggesting that, we were able to downstage a reasonable proportion of the population to resection, and I will show you outcomes of this subgroup. Overall, the toxicity was quite accessible, mostly related to chemo, albeit we do see that the addition of SIRT do increase toxicity. And the other point is that in patients with cirrhosis, and we had quite a lot of patients with cirrhosis in this study, toxicity was really increased, and I would not advocate for a concomitant treatment with chemo and SIRT in patients with underlying cirrhosis because there are a lot of hepatic failure. We did try to do some quality of life analysis. We spoke yesterday that data on quality of life for patients treated with biliary tract cancer is quite insufficient. So we had some data. During the treatment phase, quality of life was maintained. So this is quite nice. And after the end of the treatment, we do see improvement in the patient who do have long-lasting responses. So in conclusion, from these small multi-center trials, a combination of SIRT and chemo was clearly feasible in patients without underlying cirrhosis. Results were promising in terms of response rates and also in terms of survival. Quite a lot of patients could have surgery afterwards and with acceptable toxicity and preservation of quality of life. So clearly, phase 3 trial of SIRT is warranted, but we wrote that 6 years ago, and currently we are not yet be able to run this clinical trial. We can discuss maybe the reason why it's more difficult to do so. There have been a second prospective trial of SIRT run by Stephen Chan in Hong Kong. Not a lot of patients, but results are quite similar to what we achieved when they were combining with chemotherapy. So I think it's a validation of our cohort. But the main trouble was that this was a single-arm trial, so there was no comparative groups. And it's always difficult to know whether the good outcomes that we have seen is really due to the treatment, or is it only by the selection of this population with liver-only intrahepatic cholangiocarcinoma. So we tried to address that by finding a control population, so patients with liver-only intrahepatic cholangiocarcinoma that were treated with systemic chemotherapy only. And we collaborated with many people here using data from the British trials, but also from French trials, to get this specific population. And then we did what is called an emulated trial, when we try to replicate inclusion criteria and try to simulate the randomization with matched patients based on the characteristic. And of course, this is not as strong as a real randomized trial, but this analysis do suggest that we had a statistically significant improved overall survival with the addition of SIRT to systemic chemo. We continued in the same idea with a large analysis from a cohort that we have in France, the Accabi Pronobil cohort. This is a cohort of now thousands of patients treated for biliary tract cancer. And again, we try to focus on the same population of liver-only intrahepatic cholangiocarcinoma. And we had a majority of patients, 189 treated with chemo only, and quite a large population of patients treated with chemo with SIRT. I forgot to say that following the result of the phase 2 trial, the French authorities provided reimbursement of the technique in France. So now we can do that in France. This is reimbursement for liver-only intrahepatic cholangio in combination with systemic treatment. And so similar analysis, and again, a similar trend with remarkably similar figures, 15 to 22 months survival with the addition of SIRT. So this to say that we have accumulating evidence that might improve the result, but still this is low-level evidence, retrospective comparison, and not yet randomized control trial supporting that. When we first started to use SIRT, we thought about that as a palliative treatment to try to control the disease. But what we did see early on was that many patients experienced quite remarkable necrosis of the tumors, and sometimes this enabled us to rediscuss at the MDT whether this patient can be resected. And quite early, we did find that many of our patients can be resected. So after discussion, we did this resection. I just give you some recent example in a case that I would call borderline resectable. And this might be a way to think about neoadjuvant treatment. Sometimes the tumors might be technically resectable, but we do know that oncologically the outcomes will be quite difficult. So this is a young patient with a multifocal right liver intrahepatic angio, including vascular invasion of the portal of the right portal vein, which was, well, technically resectable, but we do know that when we have such level of vascular involvement, there is a high risk of recurrence afterward. And in this case, we do see that after treatment, we have a large necrosis of the tumors and also of the portal vein thrombosis that shrunk down, albeit it did not disappear, it shrank. And we believe that might be helping to improve outcome. And indeed, this patient afterward underwent surgery. I've currently a short follow-up of a year and a half for this patient, but no recurrence to date. When we did see this patient that we bring to surgery after a third treatment, while they were initially unresectable, we were also wondering whether the outcomes will be good, because maybe we talk about a bit about downstaging. Maybe this biology will be bad, and a lot of these patients might recur early. So we tried to see what were their outcomes. And in blue, you have the curves of the patients that can go to surgery upfront. So initially, resectable intrahepatic cholangio. So these are quite what we usually see in an intrahepatic cholangiocarcinoma surgical series. And we did look at two groups of patients. In yellow, patients that can be resected after initial chemotherapy, and in green, patients that can be resected after chemotherapy and SIRT. And indeed, we did see that their outcomes were quite good. So this is reassuring that a patient that can be bring to resection after downstaging should be discussed and try to be resected, because they might achieve long-term survival. And also that might question the role for neoadjuvant treatment. So currently, what are the positions for local treatment for intrahepatic cholangiocarcinoma? Indeed, there are no strong evidence. So local regional treatments are discussed as an option, but indeed it is recognized that in liver-limited intrahepatic cholangio, following initial standard of care chemoimmuno, we can discuss such local therapy, and importantly, in case of response, we need to discuss again surgery. Another important question is the relative positioning of SIRT with other local regional treatment for intrahepatic cholangio. And this is some concept, and the figures are certainly not real ones. But we do have different local regional treatments apart from surgery. Surgery is the standard of care when it's feasible. But we might think about additional treatment. And for example, we can think about ablation, radiofrequency ablation, when we have some surgical contraindication, frequently in cirrhosis, we can think about this treatment. Maria talked about external beam radiation. SIRT is certainly a very, the best case scenario is a large unilobar lesion. And these are the cases when we can think, secondly, of a resection when we do have some downstaging. But there are also alternative type of intra-arterial therapy, such as hepatic arterial infusion of chemo, which might be delivered even if the tumor spread to both lobes. I have said that the current level of evidence is weak without any randomized trial. There have been an attempt for a randomized clinical trial, which was called the SIRT trial, but the trial was terminated early due to slow accrual, according to the sponsor. We are trying to do a randomized control trial in the neoadjuvant space when intrahepatic cholangio are operable. So the current standard of care is upfront surgery, following by adjuvant CAPE. And we are trying to randomize versus an experimental arm with SIRT as a neoadjuvant. And this is ongoing. We have now 18 patients enrolled in this study. So in conclusion, there are multiple retrospective series with now more than 2,000 patients treated that supports the activity and safety of SIRT for intrahepatic. However, the prospective data are much less overwhelming. We have 2 single-arm trials that confirm the results, but there are lots of questions. We have no comparison with other local regional approaches, no clear randomized trial showing the superiority of a chemo only, and there is the question about the combination with immunotherapy. SIRT is included in some guidelines, ILCA, ESMO. Ideal population in my mind, good performance status, lower tumor burden, probably unilobar disease. And I believe that doing that first line in concomitant with chemo do bring the best results. So I thank you for your attention.